God. Okay, good. All right. So all of you are teaching. Soumya is associate professor. Soumya, what is andragogy? What we're doing just now is andragogy. So what does it mean? What does this word mean?
Methods of teaching.
Yeah, but what type of audience?
Various audience techniques is used for.
Yeah, I know. I agree with your answer, but it's specifically about a certain type of audience. What type of audience? Method of teaching who? Adults, okay? So this is andragogy is a definition of art and science of helping adults learn. Adult education is different from school education, yeah? So what we are doing now is adult education. So all of us are mature consultants. Almost all of us are out there doing our practice. But andragogy is a word that is used where we talk about techniques of helping adults learn, okay? So anybody knows what are the techniques that you would use if you had to teach an adult? Go ahead and take your guess. There's nothing right or wrong. It's easy stuff, nothing complicated. Just the definition was complicated. What are the methods you use?
Setting an example.
No. When you're teaching adults, what are the ways you teach them? What are your teaching methods? This is a common question asked. This is a breaker question, icebreaker question. So how do you teach? What am I doing just now?
Interactive sessions.
Interactive session. Okay, good. What else? So there's a way these are classified. So take me through how we talk about it. So one is lectures. Yeah, that's a common one. Then seminars. That's another one. Problem-based learning, tutorials, and one-to-one teaching. Okay, please remember these 5 or 6. This is the theory of teaching and learning. Okay, and very often, particularly in an interview, when you're going as a consultant, I will ask you this question: what are the various teaching methods that are available to you? Okay, so can you tell me some benefits of each one of them and some problems of each one of them? Today we're going to discuss all different topics, okay? So if you find one not interesting, just wait. Something else will come along which will be more interesting. But anybody wants to tell me, are lectures effective? What about efficiency for lectures? Are they good? Is efficiency good for lectures?
No, sir. Depends on the audience that they are lecturing to.
So there are 3 ways to answer, the 3 points that you have to look at each one of this. One is the efficiency of the technique. The second is how much active learning can happen. And the third is feedback that you can give to the patient or to the student. Okay. So lectures, what do you think? How efficient are they? For me as a teacher to do a lecture, is it more efficient or less efficient?
Efficient.
Come on, guys. This is
efficient. 100% efficient.
Actually, highly efficient, because at one time I can address 1,000 people or 500 people. So as a technique, it's highly efficient. Okay. But when you're learning, what do you think? Is it efficient or not efficient? For the student, listening to a lecture is efficient or not efficient?
Your lecture totally efficient.
No. Just talk about theory of teaching.
No, sir. It's the way of teaching.
Is a lecture efficient for a student or not efficient?
Sir,
it is efficient to an extent, definitely.
Yeah, but most of the times actually lectures are not that efficient, because if you're sitting in a group of 100, your attention span is just a few seconds or there's too much distraction in a group of 100. So usually they say that lectures are actually very, very inefficient way for the student. For the lecturer, it's a great way to reach out to more people, but for student, it's not such a great way. What about feedback that you can give to the student in a lecture?
To the student or to the lecturer?
To the student. Because this is all about the student.
Yes.
So is it good or bad?
It should be good.
No, actually, when you're teaching 100, I cannot give individual feedback, right? So actually the feedback to the student is very bad when you're doing a lecture. Yeah. Okay. Seminars. Anybody can tell me, is it a good medium? Is it an efficient medium to teach?
Yes, sir, because two-way interaction.
So seminars are medium efficiency. You do have a smaller group, but you do have a decent one-to-one interaction as well within a seminar. What about learning? Is it good for the student in a seminar?
Yes, sir.
Yeah,
Yes,
yeah,
sir.
learning is good because it's a smaller group. So the learning is good. It's not a problem. And feedback to student in a seminar, small seminar?
Actually, it's good because you can interact with the person who is doing the seminar, and you can ask questions.
So seminar versus one-to-one teaching, what has better interaction?
Seminar, sir.
Seminars? I think
Seminars.
one-to-one teaching will be a better interaction, isn't it? Because you
Sir,
are focused completely on the student.
Of
So
course.
if it's a one-to-one teaching, I'm completely focused on you. I can give you feedback very, very well. But a seminar has an advantage that you can get a group dynamics going.
Yes.
Okay.
Maybe the perspective of one person might not be enough for all the questions to be answered.
That is true. That is absolutely true. There are pros and cons to all of this. But it is important to know what are the benefits and what are the disadvantages. So one of the disadvantages of one-to-one teaching is that you may not have a broader perspective. The discussions may not be very interactive, but a teacher can give 100% attention to one student. So the reason why I brought this up is this is actually one of the questions that gets asked. And this is the slide that you have to sort of understand. Because the question that we do usually is that if you have to teach a medical student. Hello? Yeah?
Yes. Yes.
We lost you for a
Yeah,
moment.
who's that?
Yeah, now yes.
Sorry, who's that? I'm actually in the middle of a lecture, sir. Can you call me later? I'm actually teaching online at the moment. Okay, thank you. After about 2 hours. Thank you, bye-bye. Sorry about that, guys. Yeah. So the reason why I put this up is very often in the exam, we might ask you, or in an interview, we might ask you that if you've got a medical student or a group of medical students, what would be the best way to teach a medical student? And so this is why you need to know these things, that there are various ways of teaching and there is a various way of picking up what is best for different groups. Okay. So anybody can tell me about problem-based learning? Anybody knows anything about problem-based learning? This PBL, what does that mean? What does PBL mean?
Yes. You are going to look at a scenario and discuss regarding what are the aspects of the scenario that you need to evaluate and to solve the problem based on the scenario.
Good. So it's a very good method to teach. If you give somebody a clinical scenario, so we do that very often in our lectures, where I give you that here is a 30-year-old patient who has come in with hemoptysis. What are you going to do next? That is called as problem-based learning. So you give a problem and then get the group to discuss how you will solve the problem. Yeah. So what are the advantages of problem-based learning? What do you think are the advantages of PBL? Just discuss with me a lot, because this session will work only if we talk. Okay.
So you can.
It's a way like you'll. Yeah, go on. Sorry.
Yeah, 1%. Fitun, you can talk if you want to. Go ahead.
Okay, sir. It's like, to me, problem-based learning is a way like you will remember the exact problem if you are in the real situation.
Okay,
so
good.
you will
That's
remember all the steps that will be discussed. And so it's the best way of learning.
Good. So you can actually dedicate it to the needs of the student, isn't it?
Yes.
So like you guys are appearing for exam. So when I plan a teaching program for you, I always try to highlight things like hemoptysis. That is something that is your need of the hour. So I can, make it student centered. So it's a very, very huge advantage to use problem-based learning, student-centered problem-based learning. The other advantage is you can increase everybody's generic competency. Okay, you can have deep active learning for the patient, and you can utilize a constructive approach to develop the core skills of a person. These few words which I have put here are actually directly from the GMC guidelines for how you should teach a person. That's why I'm putting these up for you. These are different from what you would learn in any textbook or any other thing. So that's why I'm trying to highlight some of these points for you. So what are the disadvantages of problem-based learning?
Yes, limited topics will be covered.
Limited topics. Yeah, you're right. So you reduce the number of topics, and if you want to give individual attention to individual groups of people, then more staff is required. You need more than one lecturer in the room to discuss with small groups. So you're right. There is more staff required. Limited topics are there. What else can be there with problem-based learning?
Not
Any
all
other
of the
side
aspect
effects?
of the theory is covered.
Yeah, so information overload, you're absolutely right. So too much, you have to read too much. If you can get bored by the discussion. What other problems? If you're working in a group, what are the problems you can have?
Not all members will be on the same platform.
Absolutely right. Group dynamics will not work. Sometimes some group member may not be on board with you, and the whole teaching will go haywire. Okay, one person can upset the whole teaching. Okay, so this is really important to know. And other thing, what is the importance of a tutor in a problem-based learning?
It is to guide the discussion towards.
So if a tutor is not there, do you think it's good?
Sir, because of the group dynamics, the discussion might not be properly done.
Absolutely right. Absolutely right. Because you need a tutor to facilitate the discussion. If you cannot do a problem-based learning in a small group, if there is no tutor who's facilitating the direction of flow, you will end up having too much discussions of everything else rather than the topic that you're discussing. Okay. Anybody knows what is learning cycle? You know audit cycle? Hello?
Yes.
Yeah.
think
So
I know
tell me what
something
is
on
learning
learning.
cycle? So tell me learning cycle. Some steps in a learning cycle.
So we say listen. You can say listen to one, and then read it, then teach it. Right? This is roughly, yeah.
Yeah, I like that. But that is actually not the right way to teach anybody. Listen to one, see one, and do one. That's not the right way.
That's surgery based.
A lot of people do that in surgery, but unfortunately, that's not good for the
right.
patient,
yes.
because human. So anybody wants to just give me a cycle of how you, if I asked you the question, Fitun, if I asked you a question, how would you teach a group of medical students? What would you do? There is something called as a learning cycle. So how do you make up the learning cycle?
First, I have to have all the knowledge, thorough knowledge about the subject. I have to be prepared for that.
Yeah. So decide how you're going to teach this group of medical students. It's a very common question we asked.
I don't get the question.
Okay. No. How do you teach a group of medical students? How will you make a plan to teach? Anybody who is a teacher here? Who is Soumya, your associate professor? How do you make a plan to teach a group of medical students? This is actually, again, a UK-based question, but you need to know this one. I have seen an MCQ on learning cycle.
So one would be read up the topic.
Okay. So you decide the curriculum that you want to teach. Good.
Decide,
That's good. Okay. Then what you going to do?
Then plan the sessions.
Yeah, plan the session depending upon the types that we just said, lecture or seminar or group or one-to-one, correct? Then what are you going to do?
Then execute, teach a group of students, make it whichever mode we decide.
Yeah.
Then go back and see how much learning has happened.
How will you see how much learning has happened?
Usually in the form of periodic tests or feedbacks, questionnaires.
Assessment and feedback. Absolutely right. Assessment and feedback. Then
go back to topics that have been difficult and like go on probably to re-evaluation and
so curriculum modification. You're absolutely right. You modify your curriculum. So please look at this cycle and please remember that this is the way a learning cycle has been defined. Okay. So you first design the curriculum, then you decide, think of what is the teaching method you want to use. Once you have taught, you have to assess the students and you have to evaluate. So once the assessment is done, then you get a feedback and you evaluate how much the student has learned. And then depending upon the feedback, you modify the curriculum and go back into the learning cycle. This is just like an audit cycle, except that in an audit cycle downstairs, you have re-audit. In this, you just go back to a modified curriculum design. Okay. So these are the points that you have to remember in a learning cycle. You have to talk about the teacher, you have to talk about the learning experience, and you have to talk about the learning outcome. Okay, is it making sense to you guys or is it getting boring? Is it something different? Hello?
Yes, sir.
Yes, definitely it is.
Yeah, it's something different because occasionally we like to have a sort of discussion with you guys based on that. Anybody's got any views on web-based learning, what we are doing today? Is it good? Is it bad? Should it be done? Should it never be done?
So this is good.
How do you do web-based learning? Tell me some techniques of doing web-based learning. Again, this was an MCQ, by the way. I came across this in the MCQ.
This is by 3 ways, sir. One, reading, searching on a web and read it. Second, a personal meeting like we are doing.
Okay.
One, and
yeah,
third is you find a material, and upload in a software where it like a PDF page can be audible through a.
So first is emails, because a lot of people nowadays send you hyperlinks on emails. Yeah. So a lot of you publish a what you call it, a small page and then send it out on emails. So that's one technique of using web-based learning. The second is hyperlinks to further readings. Yeah. So within the emails, we can give you a link and you can go to a further reading. The third is what we are doing just now, live web conferences, virtual lectures, and interactive learning platforms. And because nowadays this is the hot topic, okay, because Zoom is a hot topic, very often we like to discuss this with you. So you must know, I'm trying to put some points so that whenever I ask you a stupid question like, tell me about web-based learning, you must have some points about to say to me in the exam or in the interview. Okay. So this is quite important to know how web-based learning is done. What is the advantage of web-based learning?
You can cater to a wider audience, sir.
Okay.
Especially
So
in
numbers
these
can be
times.
high. Absolutely right. What else?
Save time for everyone.
Time for everyone. If it's a higher number, then you may not have. It's a smaller number, you may have time for everyone. You're right. What else?
Can be done from home.
Can be done from home. Huge advantage. Huge advantage. Can be done from home in your own time, like we are doing today at 10:30 in the night for India time. You would have never had this 10 years ago. Which teacher would come to your house at 10:30 in the night and teach you? You understand? So huge advantage of web-based learning, that it can be done at home in your own time. What else? What is the advantage to me? As a teacher, what is the advantage to me?
You also teach from home.
Yeah, so I can do it in my own time, but more importantly, what do I get? Get back. What can I get back immediately from you?
Feedback, immediate feedback.
Immediate feedback. I can straight away, you guys are chatting on the side. I can see that a lot of people are chatting on the side. That is the feedback that we are getting. Okay, so you can get immediate feedback to how you're doing. And last but not the least, you can do self-assessment by using MCQs, and of course, learning at home. That was the most important point which you made. Okay, any disadvantages to web-based learning?
Largely depend upon the internet connection, actually, sir. So
Yes, you're absolutely right. In the third world, this is a big problem: internet connection and Wi-Fi. What else?
If the person whom we are teaching, they don't have that equipment, then we can't do this. So,
okay, but nowadays everybody's got
yeah,
mobile phones. So yeah, you're right. I'm not saying no to you, but more important other issues which we can have. Any security issues?
Yes, security issues, copyright issues.
Very big, a lot of security issues, lot of security issues, because password can be shared between people and people try to hack your computer. So a lot of security issues with web-based learning. Anything else? If I give you a task, a homework to do, is there any problem with the web-based learning?
Compliance with is a problem.
Compliance meaning what? Just tell me a bit more detail. What do you mean by that? I agree with the compliance part, but what do you mean by that?
If you're given a task for us to do and get back to you, the compliance might not be complete by all
you
the
mean
students.
to say you will not do it in time? Okay, yeah, but
yes.
More importantly, if you did it, what is the problem? I don't know if you've done it yourself or is it just copy and paste.
Yeah.
Yeah, the original work I cannot verify whether you have really done it or you've just copied and pasted. So authentication of original work is a real problem with web-based learning. Anything else? Any other disadvantage? Any cost issues? Cost
yes,
issues?
sir. The Zoom subscription or the on which the platform we are paying,
absolutely. So there is a setup cost and a recurrent cost. Yeah. So that is a problem. There could be a setup cost and there could be a recurrent cost. Okay. Danesh, if you had to, sorry, who was that? Say something.
I mean, subscription fees for the course or
absolutely cost of the course may be expensive, and you might have to keep paying fees for every lecture that you attend. Luckily with me, you don't have to do that. But with a lot of other teaching, it is true that cost of the course can be very high. So you're right. Okay. Now my question, other question to you will be, Danesh, or
yes,
who
sir.
wants to take it? Danesh, you're happy to take? Okay, Danesh, I tell you, tomorrow I want you to do a presentation. What are the principles of writing a PowerPoint slide?
Yeah, the principle should include in the questions form whether my presentation will fulfill the need of the audience or not.
Okay.
So
yeah,
depending
target
on
should be identified. Very good.
Target should be identified, and we have to split our topic in the form like the definition or introduction. Then the main if it's basically biological topics like pathology, histopathology, the pathogenesis, physiology. After that, then the investigations and management part. You have to split
so tell me, how will you make a slide? I just want to understand what is the best way to make a slide. Tell me some principles of making a slide.
Sir, there should be brevity of the written literatures.
Excellent. Most important. The slides should not be busy. What is an ideal number?
The ideal number is the words should not be not exceeding more than 20 or 30 words. Ideally, it's the in your slides like they are putting the 5 or 6 key words. So
yeah, sure. Okay, so you have to use keywords. Very good. What else?
And
Look at this slide and tell me everything, all the advantages of how you create a good PowerPoint slide. You know, I ask this question when I want to know what are your computer skills.
Yes.
So tell me.
There should be
This
heading to
slide,
the slide, sir.
My question to you is, the slide which is in front of you, is it a good PowerPoint slide or is it a bad PowerPoint slide?
It's a good PowerPoint slide.
Okay, so why do you say it's a good PowerPoint slide?
There's a heading for the slide that we are for the topic.
Yeah.
And there is a good contrast between the background and the
very
letters.
good, very important. The contrast has to be very clear. You must have
And
a dark background and a light foreground. This is mandatory, because otherwise, if you're sitting at a distance of 20 meters, you cannot read it if there's a fancy background.
And
the black background has been put for a reason, because you should be able to read it. So there are 3 contrast colors we have used here: black, blue, white, black, and yellow. You understand the contrast? So very important.
Yes.
There should be brevity of words. Agreed. What else?
And the size of the font should be adequate, sir.
Absolutely right. It should be a large size font, at least 20. Okay, the size should be greater than 20. Okay,
and not
so this
more,
is how we do that.
Not more than 7 words in a line.
Actually, it's 7 words is the key word. 7 words and maximum 40 words per slide, but never more than 7 words per line. That is absolutely right. Okay, so this is just in case somewhere somebody asks you, what are the rules for making a PowerPoint slide? Just, you know, this is just a flash for you to remember. Okay, Ali Ahmad, come in. How will you assess your student? When you're teaching, how will you assess the student? Whether is he doing well? How will you assess that he is learning or not learning?
Most important thing is that when you cross-question him, whether he is able to understand the concept or not.
Absolutely. So verbal questioning. Good. What else? How else?
Written feedback.
Very good. Written test or a written feedback. Verbal questioning, I agree with you. What else?
And exams.
Exams, yeah, so that's written. What else?
How he is applying his knowledge.
So will you give him some projects to do and submit back to you?
Absolutely.
So work-based projects. Good. And the last, how else do you, in a surgical field or in a medical field, how do you assess whether the whether the student is learning or not?
How does he basically practical.
So what is that called as? You're right. You're absolutely right. But what is that called as? Use the word. Yeah, you're right. Clinical assessment. But what is the terminology we use in teaching or in surgery?
His approach.
Skill-based. Okay, we talk about skill-based. Skill-based. So we need to assess what are the skills. So how do you make skill-based assessment? If you have a trainee and you want to assess whether he knows to operate or he doesn't know to operate, or in an exam, I want to actually assess whether, do you know how to tie a suture? How can I make that assessment?
Give him the practical suture and see whether he can do it.
So what's that called as? In the UK, there is something, in PLAB, there is a special section for skill-based assessment. What is that called as? Anybody can take it. After you pass your vivas, you have to go and do some stations. What is that called as? That word you must know.
American-based.
You can do American or UK, I don't mind. But what is that word called as?
So reproduction of the knowledge.
Yeah, but what is the word that we use? It's a standard word used. Have you heard of the word OSCE? Anybody's heard of OSCE?
Yeah, it's
so
a
what is
pattern.
OSCE? Tell me the full form of OSCE.
OSCE, sir, observed structured clinical examination.
It's actually objective structured clinical examination. Okay. So remember this word OSCE. So whenever you're discussing with somebody and talking about assessments, use the word OSCE. So what can you assess in an OSCE? We do this in the long case. So what are we assessing when you're doing a long case?
Sir, we can the presentation skill of the person, then the surgical
start with
skills.
the basics. Start with the basics. When you go to the patient, what am I observing?
So first is to ask the interview to know the name, CR number, confirm the site size.
So
And,
history taking. History taking.
Yeah.
You're right. Next is somebody said presentation skills. So we are looking at communication skills. Okay, it's very important. Then we may actually judge you on some resuscitation platform. We may judge you on data interpretation. We may judge you how you do a test. So I might ask you to show me the clinical examination for a thoracic outlet. So clinical examination. Or I may ask you suture, put in a stitch on this model that I've placed in front of you. Put in a laparoscopic stitch. So I will look at clinical procedures. Okay. So these are the ways we judge any person who's going for an exam. It's called as OSCE. Okay. How will you assess the competency of a trainee? Ali, you must have had some trainees with you over the years. How did you assess that the guy can operate or do a coronary surgery?
Most important thing is before letting him do it, ask him about how he will tackle an complication.
Okay. But that would, if it's a young trainee, it might put him off. He might get more scared than doing it. So if it's a young trainee, how will you tell me that he can do a coronary anastomosis? I agree with you. Complications, how to handle is very, very, very important. But if you jump into complications straight away, then the guy will get scared.
Sir, first to give some animal model and tell him to practice on that, and then we'll assess how he can do it, sir.
Yeah. See, this is a very important question in the UK, is assessment of competence of a trainee. Okay, this is frequently asked in discussions, and it's quite important that you must know how we assess competence of a trainee. So what is the trainee supposed to show you to show his competence?
Basic skills, basically. Basic.
So
skills.
he has to show you his skills. That's one. What else?
So we have to start with the indications of the procedure.
No, I'm talking about a trainee's full career. You know, you are assessing the guy that he has done 5 years with you, okay? And you have to sign his thesis and say that he is fit to be a cardiac surgeon. How will you assess the guy? This is a very important question, by the way.
Basic knowledge, clinical skills, and operative skills.
Yeah, so how will you assess his clinical skills or operative skills? What does he have to keep?
So he should be a safe surgeon, first of all.
Yeah, but how do you know that? How do you know
A logbook.
A logbook, absolutely right. So first and foremost, you assess a logbook. A logbook is part of what document?
Surgical training, sir. What work he has done.
Do you know what is a professional portfolio? Yeah, a professional portfolio is a portfolio that all trainees in the UK have to keep to prove every year that they are making progress. And that includes your logbook, that includes your audit, that includes your feedbacks from the patients, that include feedbacks from your seniors. You also include clinical records, you include database, you include appraisals. Okay, so there is a lot of things that goes into assessment of competence in a trainee. I'll just flash the slide to you, okay? This is what you have to answer. When I ask you the question, how are you going to assess competence in a cardiac surgery trainee? This is how you assess competence, okay? You actually have to go through his professional portfolio, which includes everything, all documentation of his training, including his logbook. Anybody knows what's a 360-degree appraisal form? This is an important terminology. 360-degree appraisal form. What does that mean? The second line, the third line will explain to you what is 360 degrees.
So that will include all the data. That will include the surgical summary, his training, his particulars, and his improvement, his previous work which has been done by him.
So you're right, Dennis. 360-degree appraisal means feedback from your trainer, but your feedback as well. You know, your feedback. So feedback from the trainer, the trainee's feedback, feedback from the patient, feedback from the relative, feedback from the nursing staff, feedback from colleagues. So it is a 360 everywhere in your life, in a clinical circumstance where you are there. All the people that are surrounding you, they all add together to give you what is called as a 360-degree appraisal. Okay, please remember this word 360-degree appraisal. It is a common terminology used in the UK, particularly when we talk of appraisals. We talk about 360-degree appraisal, which means everybody surrounding you, including you, your own reflection log. Do you know what is a reflection log? Anybody knows what's a reflection log? Reflection log. The reason why I'm doing this lecture is because a lot of terminologies the international students have never heard. They have never heard of these words, and they wonder why the exam didn't go well, or why I didn't get a certain job in a certain interview. Anybody can tell me what is a reflective log?
So the mistakes are clearly highlighted in the log and what the action has taken.
Yeah, so reflective log is something that you go home in the evening and you write down. And in that, you first write down what was the event, what happened during the event. If it was a good event, it's good. If it was a bad event, it's good. It doesn't matter. But you have to make a reflection of everything that went wrong. You have to then make a note of what you did to undo the wrong things. And then the last point you have to put is what in future will you do to change your practice. This is very much part of GMC revalidation program. In a GMC revalidation program, one of the first things that we look at when we appraise somebody is the reflective log of the person. The reflective log comes from the trainee. The trainee writes down in his portfolio everything over the 5 years, some things that went well and some things that didn't go well, and what he learned from those things. Did you understand that? Hello? Is it making sense or is it getting boring?
No, sir. We understood.
Please tell me if it's getting boring. I'm happy to move to another topic. But these are things you must have never heard of. That's why I'm using these words. Reflective log, okay? It is a very important part of revalidation for GMC. Okay, so now my next question to you will be, what is revalidation? If you're guys going for FRCS exam, you need to know the UK system. So that's why I'm asking you these questions. What is revalidation?
It's reassessing the competency when after you've taken a GMC registration in order to renew it.
So how often is revalidation done?
I think every 3 years, sir.
No, that's incorrect. Anybody else wants to? You can take a guess. It doesn't matter if you're wrong.
Sir, once in 5 years.
Once in 5 years. Absolutely right. It's once in 5 years. So in the UK, the way the system works is when you join a hospital, you have somebody called as a responsible officer, okay, who takes over the responsibility of your appraisal. So every year I have an appraisal with an appraiser. The appraiser sends my report, even at my level, at all levels, senior to junior. My appraisal is then sent by my appraiser, who is usually a colleague, can be a junior colleague, can be a senior colleague, and he sends it to one person within the hospital who's called as a responsible officer. The appraiser will highlight any problems or any issues that are there with a particular doctor. The responsible officer will then look at the issues, and then he will make a recommendation to the GMC that this guy is okay for this year, let him go on to the next appraisal. And when I have had 5 appraisals, then at the 5th year, I will have what is called as a revalidation, which means that GMC will relicense me for clinical practice. Okay? Is it making sense to you guys? Is there anything that you didn't understand what I just said?
Yes, sir. Just I can ask one question, sir.
Yeah, ask. This is the chance for you to learn
actually,
the UK.
In the current exam, we faced one question in which they asked how will you do the CEO appraisal?
Yeah,
the Chief
absolutely
Executive
right.
Officer appraisal.
Yeah.
So there
So we'll talk about appraisals in a minute. I will, DK, I'll talk about appraisals in a minute. I've got a few slides on how to do appraisal. Okay. So
Sir,
it doesn't matter whether it's a CEO or whether it's a colleague or whether it's a junior doctor, all appraisals follow the same pathway. Okay. And it comes in the MCQ, by the way. Appraisals is part of an MCQ. Yeah, so I'm telling you, it comes. I'll show you. My last slide is appraisal. Let me show you that. Okay. So because you asked, I'll just go to that slide. So in an appraisal, what you have to do is you have to show evidence of CPD. What is CPD? Anybody knows? What does the word CPD mean? You have to talk the language of UK. If you're doing FRCS exams, you cannot use the word CME. You have to use CPD. What does CPD stand for? What is CME?
Continued medical education.
Continued medical
so what
education.
Is CPD?
Continuous professional development.
Absolutely right. Continuous professional development. So instead of just talking about medical education, CPD is a much broader spectrum. So like I have done a medico-legal course, okay, or I did an ethics course. All of that is part of my CPD. Okay, I don't have to necessarily do thoracic surgery or VATS education. I have done an appraisal course. I am a certified appraiser. I've done a course, a full 4 hours CME with a full day actually CME where I attended the CME. So it goes into my CPD portfolio. Okay. So instead of using the word CME in the UK, we use the word CPD, continuing professional development. Okay. Okay. Then what do? I show evidence of quality improvement. That means I am actually looking at my practice. I'm making sure that I know what I'm doing is correct. My results are good or not good. I'm doing audits, things like that. The next thing I would do is significant events. Reflective log of a significant event is mandatory in an appraisal. I have to write, like my last appraisal I wrote, I had a bleed from the main pulmonary artery, right main pulmonary artery. And then I wrote the whole thing about how I went about managing the bleed, what I did. It includes calling for help, includes calling for the bypass machine. It includes calling for the cardiac surgeon to come in if I thought that the patient was going to be compromised. So all those things. And then what did I learn from it? So I had to put it into a significant event. I will also put feedback from colleagues, feedback from patients. Very, very, very important. And the last but most important thing is review of all complaints and compliments. You have to talk about the complaints against you and you have to talk about the compliments, because in the UK, people can officially complain. Patients complain to the NHS, to the hospital. So there is a whole system of how the complaint is managed. And complaint is an integral part of risk management. So this is how an appraisal is done. So when you're asked, how will you appraise your CEO? These are the steps that you have to talk about. Okay. Is this clear? DK, did you understand?
Yes, sir, yes.
This is how an appraisal is done. Now I'll quickly show you my slide on revalidation. Okay. So see this. So a licensed doctor is supposed to have a responsible officer. He's supposed to have an annual appraisal within the framework of it's not GMP, it's GMC. So GMC has a framework, what I just showed you how to do an appraisal. I have to give a portfolio of supporting documents, which includes patient feedback and everything else. The responsible officer will make a recommendation to the GMC every 5 years that am I eligible to continue as a licensed doctor or not. The GMC will then make sure that there are no further checks. They want to make sure there are no concerns. You're not a bad doctor, your results are not bad and things like that. If there is no issues in the first 5 steps, then the GMC will say you are revalidated and you can continue to practice. Okay? Does this make sense, guys? Hello?
Yes, sir.
Is it boring?
Sir, no, sir. I had
it's
one
something
question,
different. Sir. Yeah, go on, ask me questions.
Sir, this is for revalidation. For
yeah.
someone who is not registered in GMC,
yeah.
So who will be the responsible officer that they have to write?
No, a person who's not registered does not have a responsible officer, because you got to be a licensed doctor by the GMC to have a responsible officer. A person who's not registered writes directly to the GMC. Okay. So to the clerical staff of GMC, and they answer all the things. Once you're a registered doctor in the UK, then you have to write, you have a responsible officer who takes care of your, professional development. Okay. All right. Okay. Anybody tell me how do you grade evidence? This one we've done before, but I just thought to change the topic, I thought we'll ask something different.
There are various methods, there are various scales that are used for grading evidence. The most accepted one is Oxford level of evidence. Widely accepted. There is something called as grade also.
Yeah. So tell me about level of evidence and tell me about grade of recommendation.
Level of evidence is based on the studies and what type of studies that are included in the as an evidence. And
give me a name of one significant one that we use in a lot of
level 1A is
no. Don't give me the breakdown. Give me what is it called as.
Sir, I didn't understand your question. Sorry.
What is what you just said? Level 1A, 1B, 1C, 1A, 1B, 2A, 2B. What is that called as? What type of level of evidence is that? Whose network is that? Have you heard of SIGN? Have you heard of this word? Scottish Intercollegiate Guideline Network. This is the most standard one used in the UK. Okay. So that's the first one you should say. There are many. You can say any one of them. It's not a problem. What you're describing, there are many ways how evidence is graded. Okay. So that's not a problem. But in the UK, we commonly talk SIGN, Scottish Intercollegiate Guideline Network. And how do you grade a study? Grade of recommendation. What does that grade stand for? GRADE. That's an acronym.
Yes, sir.
What does grade stand for? Anybody knows? You know, level 1 is to use the drug. Sir. Level 2 is probably use the drug. Level 3 is may not use the drug. Level 4 is do not use the drug. So what is that grade of recommendation called as? What is that 1, 2, 3, 4? What does grade stand for? GRADE. It's an acronym.
Yes, sir.
Anybody knows? MCQ question. Anybody can take it. I don't mind. Okay. It's called as grades of recommended assessment, development, and evaluation. GRADE is an acronym for grades of recommended assessment, development, and evaluation. Please remember this. Okay. Grades of recommended assessment, development, and evaluation. That 1, 2, 3, 4 grade of recommendation is this. Okay. So this is the short form for it. Okay. And so you look for quality of evidence and strength of recommendation. Okay. I'm going to ask a different question now. How will you critically appraise a paper? Who wants to take it? Quickly. This is a Viva question. In fact, in FEBTS and FECTS, We always ask this question. How will you critically appraise a paper? Who is taking FEBTS or CTS? Vikas, are you taking it? Vikas, are you there? Anybody who's taking European board?
Yes, sir. Yes, sir.
So tell me, how do you critically appraise a paper? Simple question.
No idea, sir.
Are,
What should be the
you
right
read now because all the time papers, no?
Yes, sir.
You read
First
a
we
paper,
read the
don't you? So
credentials.
how do you critically appraise a paper? This is a standard question.
See the
This is the
credentials
way the
from
question
which
is asked. Yeah.
we see the credential from which institute it has come. That is one thing.
Yeah,
then,
but if you're a reviewer, you
then
never
we see
know
whether
that.
it's a then we see whether it's a randomized trial or it's a retrospective
Good. So
study or
hierarchy
a
of
prospective study.
Good. Very
hierarchy,
good.
How, then we see whether the sample size is good or not, whether it has a good sample size or not. The number of people is there. So what is the methodology?
Shall I ask you a question? How do you calculate sample size?
For that we have to have
it's a correct sample size. When you're reading a paper, how do you know it's a correct sample size?
What is the power of the test? What is the alpha value, p value? Depending on that, sample size will be decided, and effect that
you had this question in the exam. You had this question in the exam, isn't it? How to calculate sample size? In the MCQ, there was a question, I think, or there was a question on power of the test. Okay, I will go ahead and show you how do you calculate. So what are the factors you look for when you calculate sample size?
One is prevalence.
One is how is the prevalence of the disease which we are going to study?
Yeah.
How is the effect size of the study, and our power of the test.
Okay, so first is you have to talk about acceptable level of significance. Whether you're willing to accept 95% level of significance, or 98% level of significance, or 99% level of significance. Higher the level of significance, what happens to the sample size?
Larger will be the sample size.
Larger is the sample size. Okay. So if you're willing to accept 80% significance, then the sample size drops dramatically. Okay. So the first answer to this sample size calculation is, what is the acceptable level of significance? The next thing you told me is about power of study. Okay. The third thing is?
Effect size.
Okay. Expected effect size. Good. And the last thing is?
Beta error.
Prevalence. That's right. And once you know the prevalence, what else will help you in a sample size calculation?
Beta error.
When you talk about prevalence rate, what do you talk about? What is the next thing you will talk about? Standard deviation in the population, guys.
Population. Yes.
Hello. This is straightforward question. Okay. This was not a difficult question. And this came in the MCQ, I think. Okay. This is very important. These 5 points you must know. Anytime I ask you sample size calculation, you must know 5 points. What is type 1 error?
Rejecting a null hypothesis, accepting a null hypothesis when it was wrong.
So you detect a difference when no difference really exists.
What is
that called as?
Positive in type 1 error is
false positive.
False positive.
False positive.
Okay. What is type 2 error? I'm sorry, I'm moving from topic to topic just to make it interesting.
False negative, sir.
Yeah,
False
so
negative.
It fails to detect a difference when actually a difference exists. Okay. False negative. Okay, so I'm going to come back to that first question which I asked you. 1 minute. I'm trying to move through my slides to find the question. Okay. Just 1 minute. We were talking about how do you critically appraise a paper. So go on. You told me, is the abstract structured? You told me about the objective. You told me about the study design. I like that. Randomized controlled trial or not. Is the design appropriate to the objectives? You look at the methods and results. Yeah, what else?
whether they have used the correct statistical model or not.
Yeah, absolutely. You have to look at the statistical model. Okay. And when you look at statistical model, what are you looking at? It's in front of you. Inclusion criteria, exclusion criteria, sampling size. Okay. Selection bias is very important. You have to talk about randomization. Is the study blind? Were the control blind? Was the investigator blind? Is the control group accepted or not acceptable? Are the measurements valid? What quality control was done? And more importantly, dropout rates, deaths, and missing data. This is very, very important. And last thing is erroneous factors. Okay. And the most important thing is, of course, is it published in a peer-reviewed journal, or did you pay to publish your article? By the way, this question is a very important question. Vikas, FEBTS, I was asked this question, by the way. Okay, I was asked, how do you critically appraise a paper? And it was a good 10-minute discussion on how to critically, because actually you have to critically appraise the paper in the Viva. They give you a paper, you sit 1 hour, read through it, and you come back. So before you start talking about the paper, they ask you, what parameters did you use to critically appraise a paper? You must know this answer. Okay, this is definite MCQ stuff. Okay, and definite FRCS stuff. I also ask this question on the Viva table sometimes. Okay, is it making sense or is it getting boring?
It's making sense, sir.
It's making sense, sir.
I'm sorry, it's a bit difficult, but I have a lot of questions which are different from your routine stuff. Okay, my next question is, who wants to take it? You are, Nikhil will take it. Nikhil, you are about to pass. Yes, and you're about to start a practice. Okay. How will you develop a practice? How do you develop a service? What are the steps in developing a service? You want to offer VATS thoracic surgery in New Bombay. So what are the steps that you took to develop a practice of VATS thoracic surgery in New Bombay?
I'll find out a setup where my post-op care as a high standard of care, where I can manage all complications. Once I'm through that, I can manage the complication. I'll
go in a systematic way, Nikhil. Go in a systematic way. How do you develop any service? How do you develop anything in life? What is the first thing you have to do?
What I wanted to achieve.
So what is that called as?
Objective.
Objective. But when you define your objective, what do you do with the objective?
We assess the area whether there is a felt need for our service or not. So
yeah. What do you do? What is the first step in? I agree with you. You do the research, the background research. Good. Market research is good. And then what do you do after you've done market research? What else can you do? You can speak to your colleagues.
Strategy and
speak to patients. But what do you do? What is the first step of any service development? You developed
plan a design. You develop a design first.
So what is that called as? Use the word. Use the language that managers use.
Strategic planning.
No. Strategic planning comes later on. Before that, what do you do? How will you talk to your manager?
Feasibility report.
Feasibility report. Before feasibility report, what do you do? Feasibility report is part of what document?
Proposal.
What is the technical word for a proposal?
Offer.
Project.
You're all going to kick yourself, okay? Because this was the easiest question I asked you. It's called as a business plan, okay? It's called as a business plan. In all management terminologies, when we talk about proposals, feasibilities, any other project, the document that you present to the management is called as a business plan. So any service cannot develop until you write a business plan. So now tell me, how do you write a business plan? So one is, you said you find out the market research. I agree with you. What else will you do? What else can give you information for writing a business plan?
When we are presenting our business plan to someone, first we have to introduce ourselves, then introduce that market needs these services, and we have to.
No, how do you develop that business plan? How do you know what is needed in your hospital? So what is the market research you need to do?
Felt need. Research for felt need.
Sorry, what was that? I didn't understand it.
Felt need.
Okay, so the need that is there. How will you know what is the need? Who tells you about the need?
The community people
okay, so one is community. What else? Who else will tell you about the need? Felt need. Who else will tell you that there is a need? Will your cardiologist tell you that there is a need for a cardiac surgeon?
The patient will himself tell.
So one is patient, second is community, third is who else will tell you there is a need?
Media.
No, before that, I just asked you the question. Will your cardiologist tell you there is a need?
Maybe, sir, our colleagues can tell.
They will definitely tell you. Colleagues are the most important. Colleagues are the most important, isn't it? Don't think that the cardiologist is your enemy. He is the most important person. So the first person who tells you that there is a need is the cardiologist, because if he can't find a surgeon to do his hypertrophic cardiomyopathies, then you don't know that there is a need for HOCM surgery. You understand that? So before you write a business plan, the most important person is your colleague. You have to speak to your colleagues around the hospital to find out what is the need. You look at patient feedback and complaints. You have to look at the risk management feedbacks, okay, which identifies what is missing in this service. So, everybody can be doing coronary surgery, but do you know that they need HOCM surgery, or do you know whether they need mitral valve repair service? Okay, you can ask for external bodies to look at it. You can do departmental audits, or you can benchmark it against external reports. So there are many ways how you can develop a business plan, but you must be able to talk to me when I ask you how to develop or how to write a business plan. Okay, you have written a business plan. All right. Yeah, somebody's asking a question. So you've developed a business plan. What is the next step you're going to do to this business plan? I want you to talk the language of management.
Find an investor, sir.
No, before that. Investor will never invest until and unless you show him something.
So the outcome, revenue generation.
How will you know the outcome of your business plan? Talk the language which the managers talk. Hello?
Projection report. Projection report.
Yeah, but what is that projection? In business terms, how do you do a projection report?
Feasibility study.
What is the correct word for feasibility study?
So projected income.
No. What is the correct word for feasibility study or projected income? Everything you're saying is right. But you can't just look at one side. You have to look at everything. What is it called as? Come on, guys. You must know this term.
Profit and loss statement.
SWOT analysis. Okay.
Oof.
Stop. SWOT analysis. You have to do what is called as a SWOT analysis. You cannot write a business plan and not do a SWOT analysis. No financier, no lender will lend you money until and unless you present a SWOT analysis. The feasibility plan, which you keep talking about, is actually a SWOT analysis. But when you talk about feasibility, you're only talking about strengths. But a SWOT analysis also looks at weaknesses, it looks at opportunities, and it looks at threats to the plan. Did you understand that? So you cannot present a business plan until and unless you've done a SWOT analysis. Okay. You've done the SWOT analysis. What is the next analysis you have to do? To start your practice, what is the next analysis? Quickly, come on. This is easy now. Money. What is it called as? Financial analysis. Okay. So once you've done a SWOT analysis, you have to look at what is needed, infrastructure and cost requirement. Then you go to your investor. Okay. That is when you go to an investor and you ask. No investor will welcome you through the door if you do not have a SWOT analysis of a business plan. Okay. And then once you've got that, then you implement the business plan. Most important is you review your business plan always at regular intervals. You cannot just carry on doing non-stop and at the end of the year find that you've lost $300 million. You cannot. Every 2 months you have to review your business plan. Are you making money? Are you not making money? Is your business plan profitable or not profitable? This is how you develop a service. Okay. Hello. Did it make sense or no, guys?
Yes, sir.
Oof. This is very important. All these words are buzzwords. So when I discuss with you, I want to hear about a business plan. I want to hear about a SWOT analysis. I want to hear about financial analysis. What is the cost requirement? I want to hear about where will I fund this from? I want to hear about how I will implement that business plan. And last but not the least, I want to hear about how will you review your business plan at regular intervals. Okay. Oh my God. I'm sorry to bore you with this sort of shit, but it is very, very important. Okay. All right. This is an adult level discussion. Somebody tell me next question. Next question. Anybody wants to take the next question? I will skip over a few, but I'll ask you this question. What do you mean by risk management? What are the 3 factors that go to form a risk management?
Be ready to identify a problem, analyze the problem, and be ready to solve it.
No, in a hospital setting, what are the words that you have to use? What are the 3 factors in a hospital where you do what is called as risk management?
Benefits versus risk.
First is assessment, sir.
Assessment of what?
Assessment of various risks that are involved with the.
So how do you do that assessment? How does a risk, you have a risk manager in your hospital?
So identify the problem.
Shashikaran, have you got a risk manager in your hospital?
Not that I know of.
100% it will be there. You cannot get JCI accreditation without a risk manager. I'm telling you. No corporate hospital can function without a risk manager. I'm telling you this. So what is the important thing in risk management? What do we look at?
Incident management.
Excellent. Critical incident reports. Number 1. What else do you look for when you manage risk? How will you know that there is a problem? Ali, you were saying something. How will you know there's a problem?
We ask them to submit reports for any incident happening. The report should be submitted as an SRS.
So that is one. We finished with critical incident reporting. How else will you know that there's a problem? What do the patients do?
Feedback.
If the patient had a problem, what will you do?
Feedback and complaints.
There's a whole technique called as complaint management. Okay. And then all of this gets fed into what is called as a risk register. So tell me, what is a risk register? How does a risk management decide that, say you dropped an instrument in theater, okay? How does a risk manager decide that this is a critical incident or is it a low risk incident? How does he decide that? Or say you forgot a scissor in the chest when you came out. So is that a critical incident or is it just a low risk incident?
Critical incident.
So how do you decide what is a critical incident and what is a low risk incident?
Based on the possibility of harm that it can cause to the patient.
Okay. So yeah. So is there something called as a risk register? Do you know what is a risk register? Does anybody know the table, how it is formed?
No, sir.
Vikas, do you know what is the table, how it is formed?
No, sir.
Okay, so I will show you. So there are 5 columns on the on the horizontal axis and 3 columns on the vertical axis. You must know this, okay? This is critical for JCI audit and everything. So on this axis is risk to the patient and staff, okay, which is 1 to 5. And on this axis is what is the probability of this incident happening again. And so it is, if it's a low frequency, that the chance of it happening again is very low, you get 1 point. If there is a moderate chance that this will happen again, you get 2 points. And if it's a very high chance that this will happen, you get 3 points. And you have to multiply this with this, okay? And when you multiply this with this, if you lie in this 12 to 15 area, what does that mean?
High risk.
Very high risk. Very high risk. The managers, everybody will come to your theater and you're in deep trouble. So this is how they categorize, and all this is color coded. So there is green for this area, then there is orange, and there is red. This area is all in red. So if it is in red, it's a very high risk problem, which will have huge medical legal issues. So the risk team will all get involved and very quickly get onto board and try to investigate, 1, what happened, 2, how to reduce the risk to the patient, and 3, how to reduce the chance of it happening again. Does it make sense what I just said?
Absolutely, sir.
So
Yes,
now tell me, all of you spoke about critical incident report, yeah? Everybody spoke about it. Everybody knows what it is. What are the colors of the form? Is it one form? Come on, you guys are all consultants, man. You must have filled in a critical incident form sometime, or a nurse must have filled it sometime. What does a critical incident form look like? I will ask this in the Viva for sure. What are the?
It's everything is online now. There are no colors in.
There are colors. There are still colors. Even if it's online, there are colors because you have to send copies to different people. So forget the online. Just tell me paper. How would you do it? What was the paper format? And I'll tell you the colors online as well. There is a color to the to each section. Anybody knows that? A red,
No,
white, yellow, and green. Okay, there are 4 copies that happen. Even if you do it online, when the form gets generated, there are 4 separate background colors to each form. Why is there a separate color? Who do you send this form to?
So immediate senior, HOD, hospital administration, I mean quality team, and to the CEO.
Okay, well in UK, there are 4 people who have to be informed. Okay, one is your departmental manager, then the hospital risk manager, then whoever is a theatre manager, but more importantly, the NHS England. That means it goes all the way to the government. Okay, please remember this because you're giving, FRCS exam. Please remember this. These are the 4 people. This is an MCQ, by the way. I've seen this MCQ. That who does this critical incident form go to? And this was there. It goes all the way to the government. Every single critical incident goes to the government because the funding for a hospital is directly linked to the number of critical events that you have. The more critical events you have, less is your performance index, less we will fund your hospital. Okay. Somebody tell me what is clinical governance? Clinical governance. Anybody knows the definition of clinical governance? Have you heard of it anywhere, this word?
Yes, sir. Last time only you asked us.
Okay, then tell me what it is.
I just remember the first 2 words. It's a systematic analysis of a problem, of a incident.
No, that is audit. Systematic critical appraisal is an audit. What is clinical governance? All you guys are involved with clinical governance, but you don't know what is the definition of clinical governance. It's a framework through which all hospitals, I'll just put it up to you, okay? It's a framework through which all health organizations are accountable for continuously improving quality of their service and safeguard high standards of care by creating an environment in which clinical excellence will flourish. This, please, you must know, if I wake you from sleep, you must know this. This is the key thing for all safeties, because the first thing about GMC is we want to make sure that you're a safe doctor. And so if you don't know what is clinical governance, there is no hope that you will go ahead. Okay. All right. Now I'm going to ask you a very simple question beyond that. I'm sorry, these are a bit different. How many of you have read good medical practice guidelines?
Yes, sir. Last year you told us to read one.
So have you read this before the FRCS
I have
exam,
read it.
YY exam?
Yes.
Okay. So my question
Yes,
to
sir,
you is, what defines a good doctor? Anybody can say, okay, there is no, just tell me what should be the qualities of a good doctor. I'll put up the GMC guidelines in front of you. So what should be the quality of a good doctor? This is very important, by the way. This slide is the key to all of GMC and all of clinical governance, okay? So you must know these 4 domains. In the exam, whenever we talk with relation to this slide. So what makes a good doctor? Come on, you guys should know. You are all good doctors. So why are you a good doctor?
Passionate about your profession.
Okay, good, very good. What else? If I was a patient and I had to come to you, what is the first thing I want to make sure about you? I don't care about your passion.
Trust.
Yeah, okay, trust. Before that, what else do I want to make sure about you?
Whether I am a well-equipped, well-trained surgeon or not.
Okay.
Confidence.
Confidence. What else? What are the things
Patient
you look for?
safety.
Sorry, speak out loudly, please. I can't hear.
Patient safety and results.
Absolutely right. Patient safety is the first thing. The first thing I want as a patient, if I want to go to a doctor, is to make sure that he is safe and his results are good. You agree or no? So your safety, the patient should be first. I don't care what you do, what's your personality, what it is. Patient safety is the most important thing. Okay, and if you look at this thing, safety and quality is very highly mentioned. Okay, so these are the qualities that we look for, but always patient first. Whenever you have any question asked in an exam about medical practice or a complication, you must always say, put the patient safety first. If I ask you a question, will you do this as a VATS lobectomy? What should be your answer? Would you do it as VATS lobectomy or an open lobectomy? What would you answer?
Sir, as a consultant, yes, it can be done, but there is a chance that it may be converted to open. That will be clearly mentioned.
No. You're in an FRCS exam. You are there. You have just seen the patient of lung cancer. You explained everything. And then I ask you, what are you going to operate? How are you going to operate? Will you do it VATS lobectomy or will you do open thoracotomy and lobectomy? What are you going to answer?
Open thoracotomy and lobectomy.
Why?
Because there is a long learning curve in a VATS.
Yeah, no, because at your level, you're not expected to know VATS. You know open thoracotomy, and you have to do what is best for the patient in your hands. You understand
Level
that?
Of expertise. Level of expertise.
Level of expertise is very important. So you have to always put patient safety first. Okay. So these are the points that you have to know. You must make patient safety first. Whenever anybody asks you any question about a good doctor, the first thing you must say is that the patient is the most important person, and I will make sure that the patient safety is first. I completely agree with you, Soumya. Okay, now I'm going to ask you another question. Okay, you guys are all consultants. Soumya, this question is for you. If you, by religion, did not agree with a certain treatment, what will you do? The patient asks you for abortion, say for example, and religious wise or cultural wise, you do not believe in abortion. What will you do to this patient?
Refer him or her to a doctor who would give them that care.
Okay, so what discussion will you have with the patient?
Only
This is a
scientific,
commonly asked question, okay? This is a
only
commonly asked question.
scientific discussion about what is medically possible and not possible.
Okay.
And try to restrict it to that.
If say you had a Muslim patient who is supposed to have a young Muslim patient who would really do well with a porcine valve, okay, tissue valve, and he says, you know what, I don't want to have a porcine valve, I want to have a mechanical valve because pig is haram in my religion. So what are you going to do to him?
Actually, a lot of people do tell that. So we put the mechanic. We would give them the data and we would let them choose.
Yeah. Okay. So always it is patient choice. Okay. It's very, very, very important. So if you have cultural or religious differences with the patient, then you always have to act in the interest of the patient. You have to discuss the choices with the patient, but you must make sure that the patient has the right to see another doctor. This last line is what's important. You refer him to another doctor who is equally good. Okay. All right. My next question to you is, I'm going to ask somebody else. DK, tell me, what is the rule about social media and doctors?
Sir, I can't get the question, sir. Rule about?
Social media. WhatsApp, Twitter,
yes,
things like that. So what is the relationship between a patient and you and social media?
It's a way of communication.
Should you do it? Should you not do it? This is again a common question nowadays.
Yeah, sir. In the India, we are not actually allowed to do. We are not allowed to prescribe anything, medicine on the WhatsApp.
So that's one. In India, you're not allowed by law. What else?
Yeah.
Can you share a patient's videos?
No, sir. We can't share the photographs and videos without the consent of the patient.
Yeah. So you have to take consent. What else do you have to make sure when you share?
Yeah. If we are sharing some surgical photographs, so in that case, you have to cover the face of the patient completely. So the identity should not be disclosed.
Suppose you're sharing an X-ray with me or a CT scan with me.
So the name should not be there, sir.
Yes, all identifiers, not just name, all identifiers. Okay. So social media, the GMC is very clear about it, that whatever guidelines you would use while dealing with a patient in front of you is the same guidelines you have to use when you're dealing with a patient on social media. And the best thing is to try and avoid doing any social media if possible. If not possible, then you have to take consent, number one, and number two, all identifiers have to be removed. But most important, remember, anything that you share on family and friends, social media can go back to the patient by sharing. So you must always be aware that something that you share in a small group may actually become viral on the internet. Okay, my next question is to who wants to take it? Just come forward and tell me who wants to take it. Vikas, take it. Vikas, you had a patient. And Vikas, are you with me? Hello? No, Vikas has left.
Yes, sir. Yes.
You're with me? Okay, Vikas. So you've got a patient.
It's breaking internet.
Okay. Somebody else wants to take it? If your internet you can't hear, somebody else take it. Soumya, you take it.
Okay.
If you had a patient, I mean, not now, when you were young, for example, and the brother of the patient, you treated the patient and everything was great, and the brother of the patient was very handsome and you liked him. What are you going to do?
I think there is ethically you're not supposed to have any out of hospital relation with either the patient or the patient relatives.
Absolutely right. Absolutely right. It is a strict no-no. Okay. So in the FRCS exam, if you are ever asked about personal relationships with patient, it's all about maintaining boundaries, and you actually cannot have any personal relationship no matter how much time has elapsed. Okay. So no matter how much time has elapsed, you cannot have any personal relationship with either the patient or anybody else who's involved with the patient. Okay. This is the guideline that we follow in the UK. So in the exam, if you're ever asked about a question like this, remember this. You are not supposed to have any personal relationship. Don't go middle of the road. Just say, no, you're not supposed to have a personal relationship. Okay, somebody else. Nikhil, you have...
Sorry? Then how do we solve this? I think one of the thing what I remember was that you have to refer this patient to someone else, to your colleague. You don't treat this patient if at all you develop some intimacy to the patient or to the patient relative.
No,
like
no, the medical council guideline says that while you were treating the patient and you developed an intimacy, the problem doesn't happen at that point. The problem happens when the relationship breaks down. So look here, look what it's reading. So the problem with the doctor's conduct comes after the relationship has broken down. And most of the cases that the GMC has had to face are from relationships which have broken down, and then the patient complained to say that the doctor misused his position. So the GMC is very clear. It says do not have personal relationships with a patient or his relative. Okay, that's very clear. There is no, in an exam, just go with what is. I know real life is different. There may be more situations and more scenarios where you will have different answers. But if you're doing an FRCS exam and if this question ever comes up, just say no to personal relationships. Because even if you refer the patient to somebody else, you still had a patient-doctor relationship, and that makes it ineligible for personal relationship. Okay? All right. What if you have, if a company has told you that they will send you on a holiday to Dubai if you prescribe this drug?
Of course, I will go.
What is the answer for the exam? Will you prescribe the drug?
No.
So the answer in the exam is absolutely not. What if you have invented an instrument and you have to use that instrument during the surgery? Say you have invented a type of valve, okay, like a Biok-Shiley valve or something like that, some Ali Ahmad valve, and you have to use that valve on the patient because you think it is good for the patient. What do you do?
Ethical and IRB approval is mandatory.
Yeah, but what do you have to do with the patient?
You cannot use it unless you do the animal experiments and you have...
No. Everything has been done. Everything has been done. It is in the market. And you will get a percentage for every valve that gets sold. Okay. So now you have a patient in your clinic, and you want to use the Ali Ahmad valve, but what do? Do you use it or do you not use it?
We give them the choices, risks, and benefits of all the valves.
Conflict of interest disclosure has to be there.
Absolutely right. You have to disclose the conflict of interest. It's called as a financial interest disclosure. Okay. So always, if you're asked this question, you have to say, I will disclose the conflict of interest disclosure. Okay. You have to formally declare to the patient. And when you take a consent, you have to mention that actually by using this valve, I will be getting 1% royalty from this valve. Okay. All right. Is it making sense? Is it helping you guys? I'm trying to answer some critical questions that you face in your clinical practice. Yeah. Hello.
Yes, sir.
Is it worthwhile or is it not? I can stop. I don't mind.
Worthwhile.
Others, are you feeling that it's worthwhile? Is it making sense?
Yes, sir. Yes,
Yes,
sir.
sir.
We have had a lot of dropout rates, but still, I think we'll continue for a few more, for a little more time. Okay, who wants to take it? Who else is there? Who wants to take an exam? Who wants to take this question? Let me see who is there. Anybody else who wants to take? Some new person? Sundaram, come in. Sundaram,
Yes, sir.
are you
Yes,
there?
sir.
So you went to hospital, Sundaram, and your colleague came into hospital, and you think he's drunk. What are you going to do?
Report it to the appropriate authorities.
So how would you answer this question? What are the priorities that because you won't just, if you report it, he might be sacked.
The patient safety should be first.
Absolutely right. So whenever you're asked this sort of a question, the first answer you have to give is that the patient safety is mandatory. And the first thing you will make sure is that he does not operate on the patient. And that could mean reporting it to the person or to the next hierarchy. Okay, it could mean. But also, there are two factors in this. One is patient safety. You've always got to make sure of patient safety. But the second thing is you've also got to support the colleague. So don't just let him hang and dry. He may be in depression. You don't know that. So when you answer a question like this, you have to answer it in two ways. The first and foremost important is that the patient safety is very, very important. You will make sure that he does not enter into the operating theater. If that means that you have to report it to the theater manager, so be it. The second thing is you will talk to the doctor, take him on the side, offer him some support. If you feel that you cannot talk to the doctor at a one-to-one level, then you would report it to the next higher level. The next higher level will be your departmental manager. If you feel that the departmental manager is not going to be receptive, then you will talk to the risk management in the hospital. If you feel that the risk management is not going to help you, then you will talk to the CEO of the hospital. And if you feel that all these guys will not help you, then you're supposed to talk to the medical council. Okay, that is the escalation procedure. So you must know what is the steps of escalation when you are dealing with a troubled situation. Yeah. So always patient safety first. Next is stop the guy from operating. The next thing is report to your, first talk to the colleague, report to the departmental manager. If the departmental manager does not, report to the risk manager does not, report to CEO. If you think all of them will not help you, then you have to go to the medical council. It is mandatory that you have to report to the medical council if these guys cannot, because you have to make sure that patient safety is the first criteria. Okay? Does that make sense?
Yes, sir.
Hello? Yeah.
Yes, sir.
Yes, sir.
Okay, Ali, question for you.
Please.
Sir, your sister needs a prescription for antibiotics.
I should not give her.
Okay, good. That's the right answer. You're not supposed to prescribe for who?
My relatives.
Relatives? Who else?
Friends.
Yeah.
Colleagues.
Friends may or may not be, you don't know that because very difficult to prove that. But you cannot self-prescribe. That's the first thing. You cannot prescribe for your wife, you cannot prescribe for your children, and you cannot prescribe for relatives. Friends, it's a kind of difficult to prove that. So in the UK, if you're ever asked any question about prescription, self-prescription is not allowed. Okay? It's not allowed at all. All right? Okay. Can I ask another question or are you getting bored?
Sure.
Everybody okay?
Yes, sir.
What is NICE? NICE. What is the full form of NICE? No, this is not the question. It's after that. So what is the full form of NICE? NICE.
I cannot recollect.
Okay, somebody else take it. Somebody else take it. You will be asked this question in the FRCS because you have NICE guidelines for everything. Okay. So NICE guidelines are very, very important. So you need to know what is NICE. Somebody tell me what is NICE.
National Institute of Clinical Excellence.
Okay, National Institute of Clinical Excellence. That was before Now, what is the full form of NICE? It still stays NICE, but there's one more word added to it. So it's National Institute of Health and Clinical Excellence. Okay. What is the role of NICE? Hello? Anybody can take it. Because what is the role of NICE?
They have to set the standards for the healthcare industry.
Okay, so one is best evidence, to provide the best evidence for treatment. What else?
Then monitoring also is.
So it talks about resource support. But what else? NICE is really important for something. Robotic surgery is really, practice surgery. These are all NICE areas. What am I talking about?
Cost effective.
No, pioneering technologies. Okay, pioneering technologies. So newer technologies always will not be adopted within the UK until and unless they go through NICE. Okay, so yes, you're right. Cost effectiveness is important, but it also looks at clinical effectiveness. So not just cost effectiveness, but clinical effectiveness. So the real importance of NICE is to improve health and prevent disease. Okay, it also looks at health technology, and it designs clinical practice standards for disease like diabetes. There is a NICE guideline for diabetes. There's a NICE guidelines for coronary disease. There's a NICE guideline for lung cancer. So these are the 3 points you have to talk. It talks about preventing disease. It talks about new health technologies like robotic surgery, practice surgery. And then last but not the least, it talks about practice standards for existing disease. Okay. NICE is important. It will definitely come up. What is the criticism of NICE? What is the problem with NICE? In clinical practice, what is the problem with using NICE? Is there any problem or is it good? Anybody wants to say? Hello? Okay, the problem is that if you keep following NICE, then in a way, innovation takes a backseat because you really get bogged down by the guidelines. So guidelines can be good for you, but guidelines can also pull down new thinking, new technologies. Okay, so that's the problem. The second thing is NICE is for national standards, but it may not apply to an individual patient. So for one individual patient, the NICE may recommend one drug of chemotherapy for lung cancer. But for this patient, he might be, his immune profile might be different. So he might need another drug. And if you follow the NICE guidelines, he will not get access to another drug. So that is the problem, that NICE makes it very protocolized. And so it becomes very difficult for people to follow NICE guidelines. Okay. But in the UK, you must always try and follow NICE guidelines. Okay, somebody tell me, all of you are senior consultants, managers. What are the qualities of a leader? Well, how do you, not qualities, but how do you, what are the types of leaders?
Born and made.
Born and made, okay. But if you have to talk about, in theory, what are the types of leaderships? Are all leaders alike?
No.
So what are the various types of leaders? Of CEOs of hospital? Again, this is the same question about critical appraisal of a CEO. So what are the various types of leader? How would you define yourself? You are the head of the unit. How would you define yourself? What type of a leader are you?
Autocratic, democratic.
Yeah, absolutely right. So there are 7 types of leaderships. Okay, you must know that. There is autocratic, democratic, laissez-faire, strategic, transformational, transactional, coach style, or bureaucratic. Now, you don't need to know real differences between all of them, but the first 3 are easy to understand. So what's a democratic leader?
Takes everybody's opinion into consideration.
So he takes everybody along. Very good. What's an autocratic leader?
Doesn't take anybody's.
Absolutely right. He doesn't take anybody's opinion, and he just gets. What is a laissez-faire? This is important. This word is different. That's why I put it up for you. What is a laissez-faire? You might have met some leaders who are laissez-faire. Anybody knows what's a laissez-faire? No? Okay, a laissez-faire leader is somebody who lets people do what they want to do. It's not a democratic guy. So he doesn't confront people. He just wants to stay in the background, and he lets people do and get on with their life. And he lets them do what they want to do. So in some situations, it might work very well, because if you've got all adults, very driven, say you started a new company. Okay, I'm an entrepreneur. I started a new company. I got 5 guys who are working with me. Each one is got different visions, different this thing. I will not impose my thoughts on all of them. I let them bring their ideas to the table, and I let them develop. And that is called as a laissez-faire, where you let everybody do whatever they want to do. But the disadvantage of that is if you've got a group of people where people are going to take advantage, then laissez-faire never works. It's a very bad way to deal with the clinical situation. So just know a little bit about this. You don't need to know in great detail, just a little bit about the various types of leaderships. It's sort of expected, because you are going to be a consultant after you pass FRCS. Okay, now next question is very important. This is, you must know this. What is NEWS? News. NEWS. In the management of patient, what is news?
No idea, sir.
Anybody? It's called as the National Early Warning System. You must know this if you're taking FRCS, okay? There is a news scoring system where these are the parameters on the side. So respiratory rate, oxygen saturation, whether the patient is on oxygen, blood pressure, pulse, consciousness, and temperature. And on this side is a score. And the news system allows you to find out if a patient is deteriorating. And it gives you an idea about what to do when a patient deteriorates. So if you look at this trigger, if the news is aggregate of 0 to 4, then you only need a ward-based response. You don't need to call the consultant out. If it is a higher news, then you need an urgent response. And if it's more than 7, you need an emergency response. Okay, so you must know what is news. There is an MCQ on news, NEWS. All right, okay. Fine. So I think that's enough. There are a lot of other things, but I don't want to confuse you guys with too much stuff. We've been doing this for 2 hours. Okay, thank you very much, guys. I hope this helped you. It's a bit different from what we normally do, but I thought I'll highlight a few things that we need to know when we are dealing with the FRCS exam. This is all for FRCS exam. Okay, let me stop recording. And I just genuinely want some